This program is brought to you by Stanford University. Please visit us at stanford.edu.
This presentation is delivered by the Stanford Center for Professional Development, providing graduate-level education to working professionals, online, on campus, and on-site. For more information, please visit study.stanford.edu.
Good afternoon and welcome back for the Stanford Seminar on People, Computers, and Design. I was at IBM Almaden this summer for their annual New Paradigms Using Computers conference in July. And I came back, and everybody I talked to when I got back, I said, I saw this amazing talk. This fellow, Dr. Paul Tang, was talking about all of the hurdles that he's seen over north of a decade working in information systems, what the design options are. You know, this is HCI meets the real world, and as our population gets older, and all of us are getting older, this is important stuff. And I was raving about it. And finally, Andreas Papke says to me, "Well, you know, why don't you just invite him to come give a talk here?" And I was like, "Oh yeah, right, great idea." So here we're very lucky today to have Dr. Paul Tang. Oh, and by the way, Paul is also the older brother of one of Stanford's industrious alums, John Tang, who did his PhD in mechanical engineer.
Great, thanks, Scott. Well, it's a pleasure to be here. Good to talk to you, and I'm going to confess up front that I do have a hidden agenda. I'd like to, by the end of this talk, make it a moral imperative that you work in this area, because we absolutely, as you'll see, have a defined need for your help. So the idea is really to, and the moral imperative really has to center around quality, and the quality imperative that we have in healthcare and how you could contribute and really rescue us. Want to go over some results of an ethnographic study, a technique that I really love in terms of designing these human-computer interfaces. Then initially I'm going to focus about the docs and the interface with the docs and the clinicians, but really quickly turn it around to where I think the future is, which is the interface with the consumer patients. And how transformation happens through information transparency in that domain. So first I want to start out with looking at a high reliability industry like the airline industry. And I've been to the moon and back 3 times in miles, and always invariably around 37,000 feet, the captain gets on and says, you know, we've reached our cruising altitude. The computer's telling me it's smooth sailing, safe to unbuckle your seatbelts, but if you're in your seat, please leave them on. You all know that, right? Why do they do that? Why is it such high reliability, especially considering the fact there are 5,000 of these flying objects around the country at any given time? And they're monitoring them, and none of them collide, virtually none of them collide with each other. And of course, you all know that the reason is because they're watched intensively, not by humans so much, but by computers. And the computers translating that information into the ways that humans can understand them. So that's sort of the infrastructure. What about individual planes and individual pilots? Well, let's go into the cockpit of one. So what do you notice right away, just the instant the image comes on board? Redundancy. You can draw a line right down the middle, and you have equal information on both sides. And lo and behold, the 2 people who sit here are equally well trained to fly this object with access to that information. Plus, what else? Access to the training and the knowledge that they have in order to fly the plane. Now, there's a lot of instruments and numbers, but there's also sort of a hidden secret. And you're probably going to find that. What's the user interface here that helps? Sorry?
Heads-up display.
Heads-up display, not yet. It's this thing here that appeals viscerally, as Don Norman would say. Basically, it's the artificial horizon that's taking the input of all of those calculations that happen, in milliseconds at a time, and sticking them into a way that the human not only can visualize, but can react to at a visceral level. So when the artificial horizon goes this way, the pilot human naturally goes the other way. So it's a perfect interface in terms of translating the information into a way that's digestible easily, but also in a way that the human can react to, the professional human can react to in an appropriate way. So that's sort of the dream, basically. All right, enough dreaming. Let's get back down to healthcare and talk about healthcare, the information, and how it interrelates with patient safety. So first I want to introduce a very simple definition. There's sort of technical definitions of patient safety. Let me take a simple one. It's really preventing unintended consequences. So the sign makers had two goals in mind, but when you put them in juxtaposition, you come up with unintended consequences. Same thing with healthcare. We don't grow up wanting to cause harm or make errors, but if you do two good things in a row in juxtaposition, two drugs that are good for you, they could interact and cause an unintended side effect. So let's start. Just like a passenger in an airplane, you have a passenger along for this ride in the exam room, where the patient is obviously knows the physician well. And the expectation is that you're going to arrive safely and on time to your destination. But what's the cockpit look from our side of the view? Well, before that, we need to transparency is a big deal in healthcare these days. So in order to keep transparent, this is probably what we should say as we sit down. You know, this is your doctor speaking. In the absence of computerized decision support, we're really unable to predict your course. And so I'd advise you that you should keep your parachutes on, because errors happen more often than we'd like, and this experience is not equipped with seat belts. That would be the disclaimer we should offer at the beginning. And why is that? Because what is our infrastructure? This is the cockpit that we fly. So basically, in about 90% of practices in this country, people rely on the paper chart, which is, as you know, semi-legible, semi-organized, and only semi-complete. Now, behind that good cockpit is an infrastructure as well, and it looks much like this. This is the medical record system, the department that keeps track of all those paper charts in most of the organizations in the country, hospitals or clinics. But I also got to admit here that this is a very old picture. And since the advent of Silicon Valley and all that's it's brought to us, a lot of things have changed, namely color photography. So let's go on, and how would we fix this problem? Well, this is the way we would not fix the problem. In other words, just electronifying all of the paper would bring with it all of the error-prone ways that are built into that system of record keeping. Another point, so one is you can't just stuff it all in a computer. The other point is that just giving these doctors a new way of dealing with, a new technology to deal with records won't necessarily change their practice. And that probably is one of the top reasons we don't see this system implemented in more places. Because you may find that people without the correct motivation or without the support needed to really let the system itself languish. All right, so go back to ethnography, and if we are going to design a good system, particularly an information system where we're trying to do more than just repeat data in front of the doctor, we really want them to understand, to get close to that artificial horizon. I think we need to understand, even the doctors or the computer scientists have to understand how the information, what information's there and how you would use it. So as an example, if you thought about an electronic medical record system, what do you think ought to go into it? What should be displayed on it? Pardon me?
Patient name, health history.
Health history, diagnoses, what else? Treatments, medications, those kinds of things. So let's see what it would be like. One of the interesting things we did, and this actually was done at Stanford, a researcher named Danielle Fafchant did this with me, and we basically, in the case presentation, so as you know, Stanford's a teaching hospital, and the resident will present the case, go in, see the patient, examine the patient, come out with formulated thoughts, and present that case to the attending physician. Together, these two folks will sort of consider the evidence and then decide what are the next steps. So Danielle had the idea of, let's audio record this. Because in theory, all the information that they have at their disposal upon which to make decisions is rendered in audio terms. We audio recorded it, transcribed it into 500 pages of text, and then analyzed it for data that's used, and more importantly, data that was missing. So we call it a data deficit unit. And so we already recorded 168 of these case presentations in sequence, transcribed them, as I said, 500 pages of text, and analyzed them for these data deficit units. On average, one of the things you'd say is, well, you know, if they're missing something, it's because that chart isn't there. There's the paper chart at the time. It turns out in our system, we had a backup system. We kept copies filed away just because we knew we couldn't get charts, because sometimes, on average, you would miss the chart about 30% of the time. In our situation, we had them available 95% of the time. But even if you considered only patients that have been there before, that is not new patients, 81% of the times, the two docs didn't have all the information they needed to make decisions on that patient today, which means routinely this system is flat out broken. Because that was one of the questions we had in an Institute of Medicine study that we started back in 1989 was, do we really have empiric evidence that the system is indeed broken? It seems broken, but do we have empiric evidence? And that was the motivation for doing this study. So the mean number of DDUs per case was about 4. So on average, they had anywhere from 1 to 20 pieces of missing information to make decisions on that patient that day. So that's routine practice. Now, what I think we need then is we need some way of instantly giving us the information rather than what I call a foraging technique of sort of hunting for bits of information that would give us sort of an artificial horizon on what's going on with this patient. And better yet, sort of some of the decision support that said, what can I do next to change the situation? So I thought I'd share with you some of what we heard, some of the conversation that we taped. What about related to tests and procedures? Well, this resident said, you know, the information from 1 month ago would have been useful to me that I didn't even know existed until I wanted to repeat it in the doc, and the patient said, well, what about what I already took, doc? Or, actually, you know, that's a good point, because the attending had asked a question, and a chest x-ray had been ordered in December, and I was assuming that had been checked and was okay, but actually it's not even in the chart, so I have no idea whether somebody checked it and whether it was okay, in fact. So it's clear that we would like to have results of a specific test. 36% of these questions, these data deficit units, had to deal with the result of the test. But as you can see, it's a minority of all the kinds of information we'd like to have related to tests, such as what was done by others, and importantly, why was it done? What was going through their mind? As in the case of the chest x-ray, was there adequate follow-up? What about the trend? I don't want to just see numbers. Imagine if there weren't an artificial horizon that put numbers together, what was the trend of the lab test results? If you're considering a new diagnosis, you're looking at a different symptom, and has this been explained? Has this symptom been explained before? You might think of a test that's been done. One way to do it in the old days, all we do is just order it again, no matter whether it had been done before. In the new day, you have to be a lot more cost conscious and do the appropriate test because there are limited resources. So you'd like to ask the question, has a specific test ever been done? And what you normally did in a paper chart was to flip through each one page by page looking for a piece of information, which obviously is highly inefficient, and we generally don't have the time to do that. So generally it's not done. What about status of healthcare maintenance like a pap smear, a mammogram, a flu vax, anything? These are the questions that typically come up routinely, and you can't find the information. Okay, let's switch over to medications. The resident said, well, he's on one med, he says, he's not actually sure what it's for. He takes one in the morning, one in the evening. I can't even find here what the drug is, but I think it's probably for hypertension, which is something he has. And all that is, that's a vocalization. Now these the docs don't even realize they're saying this, because this is how we've been trained and raised, and this is just the status quo. But when you hear it, audio tape it, transcribe it, it looks really not only silly, but downright dangerous, right? So this is the way we take care of patients in the old world, in the paper-based world, which I said is how most of us take care of patients. So again, it would be nice if we knew the current medication and dosages, but that answered only 15% of the questions. What they really wanted to know, what was prescribed by whom. Was this a cardiologist? Was it the internist? And why were they prescribing it? Because many drugs have multiple uses. Because you need to understand what's the goal for this therapy and what are the complications. And sometimes complication side effects go hand in hand with the desired effect. But if you don't know what it's there for, it's really hard to assess whether we're doing good. And then another common thing is, so you have somebody with high blood pressure, not controlled well enough. You may want to either up the dose or add a different kind of medicine. The obvious next question is, what else have they been on before? And there you go again. In theory, you would forge through the paper chart looking for what to do. But this is the kind of question now that's going through your mind is, what's the user interface that would answer all these questions at a glance? All right, let's move on to active problems. The resident says about a pelvic exam that was done in the ER, well, she was told it was negative, and she was started on tetracycline, but then she was told it was for yeast. It doesn't make any sense. So you see, this is basically both a forging and a detective just trying to figure out what information was there, and that's sort of half the job. So they're not doing the job of, what do I do with this information? How do I interpret it? What's the next step? What about, so again, it would be nice to have the list of active problems or active diagnoses, but what was done by another provider? What about medication allergies? The evidence that led to a diagnosis of such and such. It's common that if you get labeled with something, it'll just carry on with you, including through your insurance work, even though the initial one was a hypothesis, which may or may not have borne out to be true. But in the absence of forging through that paper record, you may not actually figure it out. And that's how mistakes get perpetuated. So that's sort of the questions. As you can see, it's much more than the simple list of diagnoses and problems, just spit it back out at me. It's answering these other questions that are so richly intertwined in every encounter, inpatient in the hospital or ambulatory care. Let me take you to another setting for healthcare, one that's more intensive, and that's the ICU. So look at this, now that we've been sort of sensitized about this whole interface issue, this is obviously a severely ill person. And you can tell that by the number of orifices that have been created. And what happens is you connect them up to whether it's infusions or electrical signal acquisition instruments, but you can see that they're all the same. So there's three IV pumps infusing something, some drug, into this person's body. They look the same to me. And you cannot tell. One may be increasing the blood pressure, one might be decreasing it, one might have antibiotic, one might have potassium, any of which changing it inappropriately could cause death. But so whether it's the nurse coming in for his or her shift or the doctor coming in to reassess the patient, they go through the same ritual of, well, what's going on here? There's no artificial horizon at all. And then when you go to the next room, you go through the ritual again. Now that's if you were good and conscientious and had the time. And that would apply to any healthcare provider, respiratory therapist, etc. So that's the kind of user interface. Compare that to the cockpit that we showed at the beginning. And this goes on with our sickest of patients, and this goes on in every hospital in America. Okay, so I haven't set up exactly a good situation. And so thank goodness things still turn out, or do they? So I'm going to show you the results of this information deprivation on patient safety. You've probably heard of the IOM study. It says, we lose 100,000 lives each year due to medical errors. Well, here's the study that was based on 30,000 basically paper charts in New York they examined and used a very conservative definition of adverse events. Usually we say something that happened because of our medical management rather than the disease itself. In this case, he said, and also either caused a death, morbidity, or prolonged stay. So pretty stringent in terms of what adverse events they considered. Well, it turns out that about 4% of hospitalizations had one of these adverse events, 14% of which led to the death, and that's how, when you multiply by all the big numbers, you get 100,000 lives. Now, the unfortunate part is over 50%, 58% were due to an error, and that would lead one to believe that it's possible these errors, potentially these deaths, could have been avoided if we had either the right systems or the right information in the hands of the folks taking care of these people. Now, unfortunately, that's the good news. The part that didn't get reported by the media was done in a subsequent study to look at the other side, the other shoe. So right now, those errors were, one, only measured for what happens inside the hospital, and two, only considered errors of commission. So the wrong drug was introduced, the wrong leg cut off, things that we physically did by commission. What was left out are all the things that happen outside of the hospital and all the things that were done by omission. So you know that you should stop for stop signs, but you don't, and that's what causes the accident. So we spend a lot of money doing these randomized controlled clinical trials to find out what works. On average, it takes us about 17 years to get what we figure out what works in the literature to what goes into practice. So those I call errors of omission. So for example, we knew when I went to med school that this class of drugs, beta blockers, if you give it to somebody who just had a heart attack, would actually reduce the deaths or another cardiac event. That was in 1981. A third of Medicare patients, those over 65, only a third of patients were receiving beta blockers who were eligible the proverbial 17 years later. Another example, hypertension, very, very popular condition. We learned in the 80s by really extensive studies about what's the risk of hypertension to a patient, what's the benefit of a drug, and what happens if you give a drug to somebody who has hypertension, does it reduce their risk? And the answer is yes. So that's done in the 80s, yet less than 25% had their blood pressures controlled under this sort of conservative number in the 17 years afterwards. And furthermore, of people who were seen over 6 times in this one study in that year, 40% of them had blood pressures over 160 over 100, sort of way over the 140 over 90 that we were shooting for, ostensibly. And finally, there was a study in 2003 by Beth McGlynn taking a look at all the things that there's no controversy. We believe in the following things to do in diabetes and hypertension and coronary disease. And it was about the flip of the coin. In other words, we did them about 55% of the time. Not because all the doctors in the country are stupid, it's that all these other things that I've showed you were taking place. Time, oversight, busy, lack of information. So that's the state of affairs, which caused the IOM to write in its quality chasm report, in the current form, habits, environment, American healthcare is incapable of providing the quality healthcare that we expect and deserve. My teenagers would say it sort of sucks, which is just a much more down-to-earth way of saying this. But this is really a condemnation of not the people involved, but just as you know, it's the systemic, the latent errors that we build into the systems that we have to fix. So let's take it the other way, the half-full way, which is, let's say Americans should be able to count on receiving high-quality, safe care. Then the two biggest things that could change is, one is the culture of how we look at things, that we consider the latent systemic errors built into the system and try to flush those out. And the other is, it's inescapable. You can't do this on paper. You just can't. So we need the information system support to be able to do that. So what if we had these systems? So this is a study that I did at Northwestern where this is about the mid-90s. So in this case, I had an NIH grant to look at what would happen if you did have a computerized system in order to support this record keeping. Well, we took a large internal medicine practice, about 35 docs, and split them into 2. So could have been criticized as being unethical to force half the doctors to use a computer back then. Now you'd probably say it's unethical to deny people from using computers. So we had a pre and a post, control and intervention. So half the docs used a new computer system, computerized record, in the same department. That's what was key. And half went on their merry way using paper, the old-fashioned way. And we looked at a number of things, but I just want to show you one bottom line thing, which is the appropriateness of decisions, the clinical decisions made on the patient. So what we did is took a random sample of patients from both doctor groups and then typed them up in the same format to try to disguise what was originally typed in the computer and what was on paper in a handwritten form. And then created a mini medical record for those things. And then asked the doctors, basically the most revered doctors in the Chicagoland area, who were blinded to which chart was from which group. And as I say, had an average age of 28 years in practice, no affiliation with the project, and said, look at the last progress note, look at the last encounter this patient had, read through that and see if the decisions made by the doctor for that visit were appropriate given all the information that occurred preceding that. Okay? Sort of a Monday morning quarterback. And then score. One of the questions we asked was the appropriateness of decisions made. So on a scale of 0 to 5, 0 being totally inappropriate, 5 being totally appropriate with the information you have at hand, what was the appropriateness of the decisions made by the docs on that last visit? So the doctors who were using paper, as judged by this blinded group, scored on average 2.5, which, as you'll notice, is actually below the neutral score. And the doctors who were using the computerized record scored 3.6, which turned out to be statistically, and I'd argue clinically, significantly better. So in other words, folks who were using an electronic health record system made better decisions viewed by a blinded panel. Now, we've talked about now the system that is doctor-facing and some of the interface issues and some of the implications and the potential for improvement on the doctor side. I promised you we'd also look at the patient side too, because I think that's the next generation of things where we need to improve both the computer systems and the interfaces. So let's look at what we do status quo, go back to the ethnography piece. So here what we did is we developed a tool to characterize information gathering activities inside an exam room. And then at 1-minute intervals by the stop clock, wrote down what it is that the doctor was doing from an information gathering point of view during the exam room encounter. And we observed 38 clinicians doing this for 2 hours apiece, 4,500 minutes of observation, and then of course reduce that to text. So it turns out that most of the time in the exam room, and you can verify this yourself, is occupied by talking, which is a good thing. Okay, so this information gathering. What was interesting, so let's break this talking time down. What's interesting is, though 60% was this information gathering that you'd expect, a full 37%, more than a third of the time, was spent actually doing patient instruction or patient education. So there was the intent, at least, to communicate information so that the patient could learn more about what's going on with their bodies and what to do about it. Now, we studied a number, we not only studied primary care practitioners, but also specialty care, those in academic medicine and those in the community practice, but and even an urban safety net clinic. So despite all the different kinds of practice, this yellow bar represents that patient education time. And you can see that no matter what kind of practice you have, you do spend a lot of time doing this activity with the intention of educating the patient. What's the outcome? Well, this is a nice Mayo study where they had 57 Mayo internists, about 458 visits. They handed the patient and the doc a questionnaire coming out of the exam room and said, what went on in there? What were the things you guys talked about? And what was the single most important thing you talked about? So it turns out, of the list of things, what did you talk about? Patients failed to report 68% of the things that the doctor said was on their list. So it's the intent. And the other piece is, more than half the time, they missed the most important thing that the doctor said we talked about. So neither party is stupid, and neither party has malintent. The moral here is, this is the wrong time. One, doctors don't learn communication in med school. That is one lesson. The other is, it's the wrong time to be talking at somebody. So the patient's trying to think of what's the next question to ask, because you want to maximize what you get out of that time, and the doctor's sort of spouting out words, and it's just the wrong time. And it's also very evanescent. So you walk out of the exam room, and it's all over for both parties. So we go back to this, and who should be in the cockpit? Both should be there, right? So we have a healthcare team that should include the patients. So let's put the patient here, and what's the difference? What's the difference in the healthcare professional and the patient in this setting?
We know about different things.
We know about different things, or don't. And in the patient world, this is the view we give them. So even though they're the only one that goes down with this plane, this is what we give them in terms of access to their very own information. Let alone none of the training, no flight simulator, none of the training or knowledge even to deal with their very own condition. So it's pretty easy diagnosis about this user interface. What if we were to change the user interface? What if we were to change the access to information and knowledge? How would the world be? So let's talk about creating transparency of information in the care of a patient and engaging the patient as an active co-pilot. So this is an example of, I practice at the Palo Alto Medical Foundation just across the street, which is basically a large multi-specialty group practice. And we have used an electronic health record system since 1999. And in 2001, we installed this thing, which is, you can consider a patient portal. Another term for it is a personal health record. Now, there's multiple kinds of personal health records. Let me just tell you about this kind. This kind is we share the same record. So the same record I'm looking at, you're looking at. We do some translation I'll tell you about, but you have access to what we have access to, pretty much. So you decide on your private ID and password, and you log in, and there are a number of things you can do. Now, one of it, we'll just walk through one scenario, is you may want to make an appointment. So Libby, in this case, is a 66-year-old woman, had recurrent back problems. She lifted up her granddaughter and out went her back again. And so she's writing about that and asked for an appointment time. Now, we're on open access, so the majority of the time you will actually be able to see your doctor today. So she has to rush in to do that. And after the experience, then she rushes home, because the minute she leaves the exam room, she has available what we call visit details, which is sort of a summary of instructions that we've given her during the visit. So if you peer into that, what you're going to see is the same thing I may have handed you as a handout. In the old days, we just handed you a printout, and people would save that as their mini medical record. Now, in the new days, of course, we do that, but we also can give you access anytime, anywhere to the information electronic format. So we talked about, now the thing about back pain, it actually is one of the biggest causes of morbidity. In other words, time away from your activities, whether that's play or at work. And it's one of the highest costs to society because of the lack of decreased productivity. Yet it's not something we have a magic pill for. It really involves the patient doing exercises to prevent the next occurrence. It's just basically a chronic condition. But the problem is you have to describe what the exercise is to somebody who's in pain and not want to do it now. And so they aren't really listening at the time, but when they do get better, that's when they should start the exercise. So the doctor goes into the charade of describing what he or she thinks those exercises are, when in fact they usually don't know. But it's nice to say, well, you should do back exercises and back stretches. And they sort of both nod, because the patient's too afraid to ask. So now, when they do have that magic question, and we have it on the internet, and we've been able to include a link, then when she does have the question, she can go to that link. And hopefully, and with PowerPoint, the new hyperlinks are harder to find. And although that's a very straightforward illustration, it's far more than they got from the doctor in the exam room, because the doctor almost certainly didn't do that. Yet that's exactly what's going to that's exactly what you'd have to do to reduce the chance of you having the back problem the next time. So that, in fact, is the intervention or the treatment. Okay, so she says the moment of truth comes. The back's getting better, and she says, well, it's a little bit achy. Do I do this now? And that's the teachable moment or the moment of truth. In the majority of cases, the way you would normally try to ask the doctor a question would be to call. And anybody who's called the office knows that's such an unrewarding experience that you generally don't do it. You don't ask the question, you don't get an answer, and you don't do it. And that's just how we recycle the low back problems. But with a PHR, and this you can ask the question 24 hours a day. Now you do not need to get an immediate response. You just want to get the question off your chest and expect in some timely way to get an answer back. So that's what happens now. The other piece then is, and I didn't show this, let's see if I have this as a hidden. The other piece is when the doctor gets your message, it's in the same in-basket that I get all the other messages I get, whether it's from my nurse or from the lab, from your lab test results, et cetera. So the important point is in my workflow. If it were yet another website from some commercial PHR vendor that I have to log into, what's the chance that's going to happen? And if I had to return back and look up your record in another system, what's the chance? So the beauty of this is I'm going to get your message in the same place I'm spending my time looking for all other kinds of information. And your record is available to me at one touch of a button. That's what makes it work. So then when I send my reply back to you, it'll go to the secure web server, and the web server will generate the "you've got mail" message. So nothing is going out in clear text by internet email. You just have a notification, come back and sign in. So you'll come back, you'll notice that you have a new message, and you'll have my response. And in addition, all of this is being recorded in your medical record, basically, instead of being lost. In the paper world, we were supposed to do that, but since you never could find it anyway, we didn't often do that. So now let me take you through a tour of some of the other parts of your medical record that's online available to you. One is, so we call it a problem list. Well, we just changed that. It's the same list. We'll call it a health issue for you. And we'll rename some of these Greek words into human speak. And then the links allow you to go to more information about that particular diagnosis, for example. You'll also see the medications we have on record for you, the allergies, immunization, and health reminders, all from our medical record. Now, if there's something, let's say you got a flu vax somewhere else, and you want to let us know, you'd click a link and have us update your official medical record. The other thing is, people have different intervals for which you should get your health maintenance procedure, like a mammogram. It depends on your risk factor. So the system already knows your risk factor and will program what your schedule should be, unlike looking it up on the internet and just sort of for a generic schedule. The most popular feature is lab test results. So here's the lipids, like the LDL cholesterol, and your actual values and the ranges for them. Now, that's nice, and you get it back usually the same day, which is far improvement over what it was in paper. But the doctor may also give you the annotation that sort of interprets this for you, and then what's the next step. Now, a doctor may be thinking that he or she's doing a good job, but saying, well, your LDL's just where we want it, and keep on taking the drugs and do that low cholesterol diet. And you're thinking that's sort of nice, but what's an LDL again, and what's even an LDL, a low cholesterol diet, just like what's a low back exercise. So we used to give doctors a library of these links, say, hey, here's some links you can hand out to people. Never went anywhere, right? So what we did was we created technology so it'll look for these words and phrases and automatically create the links to something. If you click on it, it'll be a definition that we wrote in a human speak, and then go to websites that we've personally vetted. So in this case, it's something we wrote. It could be something we licensed. It could be a .gov site. It's something that we've had a team actually look at and endorse, which is far better than just doing a search on the internet. Now, here's the transformative piece, though, which is, I think, the thing that's going to make the difference. So now that you know that LDL is the bad cholesterol and that your target may be 100 or 130, what's going on, you can graph. Now, I mean, how high-tech is that? Not very, but very, very transformative. So you guys are not old enough to take these little white pills, but most of the chronic diseases just don't hurt. An arthritis patient will take their meds. 50% of the rest of us won't take our meds. Why? Because nothing hurts. The cholesterol, I can't tell you the last time the cholesterol has been banging me in the side. And same thing with even diabetes. None of these things hurt, but they have a cumulative effect. So your feedback system just ain't there to take the little white pills. We've got it down to you only take them once a day or twice a day at most, but you won't take them because you forget, because there's no feedback. So this thing that says, here's your target, and this is what you're doing, and you immediately correlate that with what you do, whether you do or don't take that little white pill, and that's what the hypothesis is that will make you take the little white pill. And actually, it turns out we've got a randomized controlled trial in diabetes to try to see whether, in fact, this kind of thing, and there's lots of other things that go with this, will improve your management of your disease in a co-pilot seat. So I said we started this in 2001, and as you can see, we've had steady enrollment, basically. There's no plateauing effect. We now have over 93,000 people online, and that represents 46% of our adult primary care practice. So more and more, this is a way we do business. Why? Because patients want to they do everything else this way, and it actually puts you in real-time touch with your own health. Our overall satisfaction rate is 94%, so people like this. Year by year, we do a survey. And then we also get lots of free text, get over 10,000 free text messages as part of our survey that we actually have to go and categorize. So the piece that I really like is the pieces like this, where this patient likes the interactiveness between the patient and their healthcare team, or feeling connected and being a partner in health, and that's that co-pilot thing, or this person has a bit more insight and says, it empowers the patient because I now have knowledge to act as that partner in my health. So one of my favorite questions, though, is to ask, have you changed your health behavior just because of your access to the online version of your medical record? And it turns out that 25% of our patients say, just because of the access, I've changed something I've done related to my health. So the question is, what did they change? And it goes back to that graph. Seeing the graph of test results against time helped me stick to my diet. We aren't, as a profession, we're not that great at changing people's diet, helping people lose weight or getting people to exercise. But this person thinks the graph did. Another person, direct access to lipid. Now you have to understand, we don't measure LDL cholesterol that often. And yet, that incented this person to go on a low-fat diet that he or she's been on for a year now. We don't have pills like that. And it's because they got access to something they already paid for anyway. You just never gave it to them in this fashion. This one, got to be an engineer, took off 17 to 19 pounds, 16 points off the cholesterol, 30 points off the BP, because all of a sudden they have access to feedback. Again, this person is very more introspective in saying, look, this is what it does for me. Gives me up-to-date medical information, gives me my connectivity with the physician. That basically is the support structure for me doing something different about my health. And this person has diabetes. You don't think they were motivated before? What's the difference? The difference is they now have access, they have access to the data, knowledge, and tools. And the hired hand, the healthcare professional that's trying to help them. Now, from the doc side, the initial response was great. Thanks a lot. I've got a big day already, and you're saying they have another way to get at me. But what's nice is, even with the docs, we have a 90% satisfaction rate. And the reason is the payback comes from the efficiency and from the patients liking what they get. So all of a sudden, we've created not this transactional system of you come in, you have to make an appointment, and isn't it great that you have to wait 3 months to see me? Now we see them the same day or within a few days, and we give them access to their information and some information, some knowledge to do something about it. That creates a relationship, and they feel it too. So in short, in order to create a new standard of care, of health, of this relationship, the status quo is just unacceptable. And I might have painted it a little bit more bluntly to you, but it's only because you haven't seen what's on the other side to know how bad it really is. That it's really essential that we have this sort of integrated electronic health record and personal health record. And that's what's going to put the additional person in the cockpit, the additional person on the team, that I think will create better outcomes. It's essential for us to bring patient safety to care, for us on the healthcare professional side, but we need your services. This whole artificial horizon problem, you saw the ICU, which is, again, ironically, it's where we take care of our sickest patients. We have the least ability to cope with that information. We just hope you found some number up there that makes any sense to you. And that for patients, there's a whole new interface that we've got to create. And it's got to have knowledge embedded because it's got to, in a sense, translate it like the artificial horizon into something meaningful, intuitive, and visceral almost. But again, we need a navigation system for the patients to navigate through the data and the knowledge in order to do something different. And then giving them positive feedback in order to continue that. So the challenge and I think the opportunity of not just the computers, that was the electronic record, not one approach that vendors do take, and there are vendors that do that, is just to stuff all this information in the computer and that'll solve the world's problem. And it doesn't. And we have a lot of those failures as well. But the other piece is to empower the patients onto this team, and all of a sudden the ability to store and manage and then render the information back to the people who need it the most, whether it's the clinician side or the patient side. I think will be absolutely transformative in the healthcare delivery system, which, as you know, is headed for the rocks in terms of what we do. We can't do, there's no amount of money that can make what we do now, the way we do things now, to take care of the AIDS tsunami that Scott was talking about. We've absolutely got to work differently. And I think that the key is to create the right teamwork. And the key to that is the information and the way we present information. So that, I'm going to rely on you, and I really thank you for your attention. So we have plenty of time for any questions. Please.
During your talk, I sort of got the impression that you're making your presentation as a missionary. And I was trying to figure out, why is it necessary these days to convince people to use computers and do this? And I thought, well, you said that doctors, 90% of the doctors said, now they got more ways to get at me. And you said,
No, that was satisfied. So I said the initial concern was that there would be additional communication channels, and that would just fill up my already busy day.
okay,
But very quickly turned around, this is a satisfier for
but
doctors.
initially doctors would be
Right.
resistant for that reason.
It's just like saying, I got a new thing for you, I've got a new email system.
And the other thing is, I guess maybe some of them had bad experiences with computer systems not working in the past. And I'm wondering if you take those two things, plus maybe some I didn't maybe think of, and put that in the scenario of dealing with doctors, say, in their 50s and 60s versus the doctors in their 20s and 30s who are really familiar with computers, I'm wondering how that all works out.
So the number one question underlying your questions is why is it only in 9% of the practices now, if it's such a no-brainer? And let me give you 5, but I do want to bring it back down to HCI. So one is it's really expensive. It's almost always in the 7 figures. And as you can see, the economies of scale will work once you're above 50. It doesn't work for the 1 and 2 doctor practices. Another way to look at it is there's a basic system, there's comprehensive system. The basic system costs a quarter of what the comprehensive system is, no surprise. But you get 12 times the benefit. The comprehensive system has 12 times the benefit. So the problem is all of the other things so one of the problems is this economy of scale issue, because there's a high buy-in cost, the initial capital cost. Another one is, to whom does the benefit flow? So who pays for the system initially, and who has to learn it, and who has to change the workflow? The doctors. So if you say you get better care and it's cheaper in the long run, who collects the cheaper in the long run? That's a problem. So in the Kaisers of the world, or the VAs of the world, or even the UK system, where the payer also is the provider, it works great, because then the payer should pay for this infrastructure problem, and the doctors are it's just part of a tool that they use to conduct their business. But you get the payment and you receive the benefit from a financial point of view. We don't have that in most of U.S. healthcare. Next problem. We actually have some good systems, but not enough good systems that would actually deliver the promise. So there are people who went out and spent all that money, including in the millions, and then they end up not picking the right system, so they have a failure. Next problem. Even if you had a good system, had the money, you actually don't have the people with expertise in informatics. So it's not installing Word. It's not slipping your CD. You basically have this very complex, very highly configurable system, including the display configuration, and you have to build the system, implement the system, and then on top of that, convince the doctor you have to change everything you do. So you've got to be head-to-head with the doctor. And it requires, in my opinion, virtually definitely another clinician, and not necessarily an IT professional. Because this is really a different kind of piece of software. So the expertise to do that, there's plenty of people who will sell you services to go do that. There's X% yield on that. So we actually do not have enough, even with the money and the right software, we don't have the people to implement it. And then we have this healthcare financing thing, where you're actually not even incented to practice good medicine, you're incented to do the factory thing. That's just, we call it perverse incentives. And so the ability to try to excel to succeed at delivering high quality care means we need to reward people for doing high quality work. Just like you'd reward a car manufacturer for high quality products. You need to do the same thing in healthcare. And there are programs, it's called pay for performance, that are trying to do that, but that's a 1% kind of a thing, whereas it should be almost, the majority. So there's a ton of reasons why things haven't emerged. Now the other thing is, again, if I did even all those 5 things, the thing I'm going to concentrate on, certainly for this class, but I truly mean it, is this human-computer interface. The reason it's so hard to implement is because we don't have good human-computer interfaces to make it intuitive, easy to learn, and that you would actually yearn for that information coming out of that tube. The other piece is there's so much information. So all we do is create more and more technology. Basically, that's spitting out more and more data. And there is no innovative way to spell it out like an artificial horizon so that the physician or the patient can glean the information that's really there, the information content that's really there. That's a to die for kind of a thing. And I don't think, I've been in this business for over 20 years, and I actually spent time in the HCI side, and so my perspective is there's got to be a lot of knowledge put into the system in order to know how, for any one patient, how to display the important information in ways that are most meaningful for that patient. This is a field ripe for innovation in HCI, and it would completely transform the way that mortal human beings deal with this information in a very positive way. Well, there's all kind. We can go on for a long time. There's all kinds of things that have been attempted, but there's so much information, and there's different information that's relevant for a different patient, even at a different time. The simple approaches usually break down, but that's why it's a research problem. That's why it's a problem, a graduate level problem. Please.
What is your take on some of the online tools, like Patients Like Me and some of the things Health Revolution offers? Do you think they're steps along the right path, or totally the wrong concept?
Yeah. So her question is, what about, and let me lump them into PHRs, personal health record systems. So I'll put 2 ends of the spectrum. One is a personal health record system that's basically integrated with the EHR, and that's the kind I showed you here. And there's the other extreme would be one that's sort of a standalone that you're expected to fill with data. Now, one of the problems in today's world, literally, you would have to fill it up yourself and maintain it. Now, the other part is that, and then even if it has rules, it has to rely on the accuracy and the code that you put in, and whether we have the standards to codify all the information you put in so the computer could interact with it. Now, the problem is we do not have the standards, or again, it goes back to this whole market pressure stuff. Everybody wants to be the next Microsoft or Google, and so everybody has their proprietary solution, and right now they do not interoperate. So one of the number 1 agenda items for Secretary Leavitt, current Secretary of HHS, has been to try to improve the interoperability of these EHR systems for that very reason. Because you don't necessarily just see one doc. And you have information coming in from lab and pharmacy, et cetera. But the idea is if we would have the standards, the implementation guides, all that stuff that would allow information to come into a repository and be shared by all the people who need to use it. Now, as I say those words, the next thing is privacy. So some of you heard the term HIPAA. HIPAA is a federal law that guarantees access to information and also regulates the privacy of your data. Now, the loophole is it only applies to 3 kinds of groups. They're called covered entities. One is the provider group. Doctors, hospitals, pharmacies. The other is the payers, the insurers, because they have to pay your claim. And the third is this group in between called clearinghouse. Nobody else is covered, including virtually all of the commercial PHR vendors. Now, the problem then is most of them are, quote, free, right? Well, how many know that there's no such thing as a free lunch? So the business model generally is that there's other use for which financial benefit accrues to the supplier of those products. So one of the things you have to worry about, you need to certainly consider, are all the privacy questions. And I can share with you a website where it has a consumer checklist of things to look for in a PHR offering to make sure that you don't one of those gotchas. So for example, what happens if the company merges or goes bankrupt? What happens to your data? In the old world and the existing world, that's what's called an asset, and it's transferred into the buyer. So I mean, things like that. There's lots of these potential gotchas that you need to consider. But in the new world, in the future world where everything's interoperable and we understand the meaning of each data element, universally, then we can call all these application providers to come and operate and offer these new services. But right now, it's not quite there. But there's a lot of people wanting to push in that direction for sure. Please.
Microsoft, they just announced this month something called Health Vault. Can you give us your opinion about that?
Yeah. Okay, so Health Vault is a nice way of putting it. It's basically a repository of your health data. And the hope, it's a little bit like the previous question, is that if I were to consolidate all my health data from whatever sources, then there's a couple things that could happen. One, I could share it with the people I want to, let's say with my specialist, or I'm somewhere else in a different part of the country or world. The other is you could have people helping me use it, make sense of it, or create tools that would help me manage my health. But the ifs were what I mentioned. So right now we don't have an interoperable world. And so the question is how many people will be able to insert, to enter data, submit data in a way that everybody else can understand. Then you have the motivation. So how many doctors want to pay for something else to have happen so that it can go somewhere? Then and then what do we think about the data coming out? Let's say, and I don't know the rules of the game that they've set, let's say you can change some of that data. So you put it in there, let's say you can change it. Is that a good thing? Well, I mean, there's trade-offs in each one of these things. So actually, I'm on a group called National Community Vital and Health Statistics, NCVHS, that is the public advisory body to the Secretary of HHS on health information policy. One of the things we're considering right now, a couple areas. One is the privacy and confidentiality, and the other is what's labeled secondary uses of health information. Now we're trying to change that name because it seems like secondary means it's not primary. But the intent is, so you go to a doctor and you offer up some information, and you're doing that because you think this doctor is going to take care of me. You're not thinking, well, what else could be done with that data? Now there's lots of good things that can be done with that data. Public health, clinical research, biosurvey, a lot of good things. There's also some not so good things that could be done with this data, some of which can be for private gain by another party. Another is it could be actually harmful to you or people like you. But right now there are no laws that would control one or the other. And so that's one of the things that's from a policy point of view. Those are some of the important things that need to be sort of ironed out before we start spreading our data around. So again, we already have a federal law called HIPAA that does control and protects your information quite well when it's handled by these covered entities. Once it gets out of the area, it sort of falls off a cliff from a policy point of view. So these are some of the caveats. There's lots of good that can be done. So I want to make sure people understand that. And a lot of expected things that you would want to have happen. What we're trying to do is we in the sort of the policy community trying to prevent the things that you don't expect and don't desire to have done with your data to be protected in some way.
Microsoft is making progress then?
Microsoft has created an opening, and the question is how many people can play before the interoperability environment gets established. And then the other piece is this privacy piece you really have to be careful of, because Microsoft and none of the other vendors operating with them are covered entities. So you have no federal law, it's really on your own. I think there was one up there before. Yes.
So were you able to put the system together through different pieces internally in-house? Or from the understanding of, so for example, website, there's different layers that goes into building this. I'm assuming that it's all handled within the hospital within the IT department.
Okay, so let me just clarify one thing is, this is a commercial product. We use, Epic is the vendor of the product. And in today's world, for the reasons I just talked about in terms of interoperability, one of the ways you get interoperability is to have it all from one company. Because then it goes from one module to another in an understood fashion. So we did work with Epic to create this MyChart product, which is their PHR product, and we were the first customer to install that. So, and there's a lot of enhancements that we've built on top of it, but it's primarily a commercial product. Please.
I encountered some of the problems that you described minutes ago. For example, the Stanford Medical Group generally couldn't retrieve test results more than a year old. We just lost. So I started keeping my medical records in here and found that worked quite well. I later switched to Kaiser, and they have much better computerized data system. But even then, I found that they slipped up fairly often, and I could correct the record. Unfortunately, the only way I can upload to them is verbally. It would be very nice if there were simply a standard way of communicating this stuff, so that I could put that in here and, you know, ship it quickly. This solves several problems. The privacy problem is one. Nobody else has access to this stuff unless I let them have it. I think a system developed along these lines would turn out to be more manageable than sharing my data with Microsoft in general or other such entities.
Those are good points. Let me just comment on something since you talked about uploading. One of the things we're doing, this clinical trial that I mentioned earlier, is to try to help diabetics become more involved in more control of their care. Because we publish internally unblinded data about each of our physicians. So I can dial up any physician in our practice and find out how they do on a number of clinical parameters. One of the reasons we do that is because I think within a few years it's going to be on the internet. But what's great about it is you get to see how you're doing. And as all, you know, type A folks, we just keep wanting to do better and better. And what about the patients? Same thing will happen, just as you saw. Basically, once they have the feedback, they'll be able to do better. So one of the things that gets in the way of diabetics managing their care is having to write down, you know, so they test their blood, they write down the sugar in some paper diary, bring it into the doc, and it's just a very poor system because we don't get it except maybe 3 or 4 times a year, and you don't have the tools to look at it. So what we're doing is we developed a system where you have the glucometer, the thing that measures the glucose in the blood, and then it is going to go via Bluetooth to a phone, and then from the phone up wirelessly to us. And then it'll be shown back to them in terms of that graphical form that you saw. And, by the way, of course, we get access to it too. So we will use the computer to process and find out what the exception points are and let us know in a far more timely, sort of near real-time way what's going on so that we can intervene at the point of need instead of, you know, periodically at some random fashion. So in some sense, it's a little bit of what you were talking about in terms of things that you enter, because you have symptoms, you know, you have physiology going on continuously. We have this ridiculous way of sampling, and we're usually wrong. Why not do real-time samples and help both of us keep tabs on yourself and intervene at the point where we can make a difference instead of deal with the consequences? So that's, and this and a number of things we're putting into a trial to see if it actually does produce better results for patients and for the disease. Please.
I know that you have some face-to-face support groups for diabetics, and I wonder what you see about the interaction between peer-to-peer support, peer-to-peer communication, face-to-face, online, how that plays into the larger picture.
I think that's a very interesting possibility. So, and although it's not part of our clinical trial, it may be something we want to experiment with, and that is just this whole sort of moderated, I would suggest, chat room, where you can share experiences and share, you know, tricks of the trade, basically, in how you cope. Another thing we're doing as part of our alpha and beta for this clinical trial, We did focus groups, but also visited people in their homes. And because doctors have no clue what it's like to live with an oppressive chronic disease and how it affects your life. I'm not going to say no clue, but I mean, we see a very staged rendition of what happens at home. And if you go in the home, you see how things are laid out and how living with diabetes, as an example, affects your life. Well, again, it goes back to ethnography and it goes back to HCI. Now I have a better idea of how to design things that would relate to you in your life, not deal with me and my sugars. So I deal with your sugar readings, but it's far better for me to deal with you and your life. So one of the tools we produce is, this whole sugar thing really doesn't connect. I mean, we all talk about it in the office and patients seem to understand sugar, but they really don't understand what does sugar mean to me. But they could relate to, I know somebody who lost their leg and I know she had diabetes. Well, all of a sudden, diabetes is not about sugar, it's about what could impact my life, whether it's a heart attack or amputation. What if I presented, instead of your sugars initially, their chance of losing your leg in 10 years, or your chance of having a stroke in 10 years? All of a sudden, I've now related to you in ways that matter to your life. Then I can answer your next question is going to be, well, what controls the risk? Well, by golly, it's that bad cholesterol again. It's that LDL cholesterol. Oh, well, what can I do about it? Well, it's these are the drugs that affect it. Oh, and what can I do without drugs? It's the exercise and the diet. So it's the same data, but it's presented in ways that relate to the patient. Again, you have to understand what it matters to the patient to figure out how to render the information, in the computer. No, I could go on. I don't know about that, but please. Oh, I missed you. Sorry.
Yeah. I have a question. Want you to go a little more into the transformative aspect of the system. I know that you have essentially two classes of information using patients. One who interact with almost everything you have up there, and others who pay extra to actually communicate with the doctors directly. So what I want to get at is, is it more transformative to have the actual interaction with the doctor, or can you get this transformative impact through all of the other results that you get that do not involve the physician directly?
Okay, so what she's referring to is all of the stuff I showed you is free to the patients except for messaging with the doctors. And for that, we charge us a $60 per year, all-you-can-eat kind of a fee. And one of the reasons is, there's a professional component to that. And if we don't help subsidize running the system, which is done, of course, again, as we talked about earlier, at the doctor's cost, then it's just not going to. It's just sort of no money, no mission kind of stuff. So that's a subsidy. It doesn't actually, pay for the whole cost. But it's a way we sort of recognize the professional component of that interaction. It also turns out that unlike some of the health websites where it's really the word well that go, so that's a WebMD kind of experience. In our case, the folks who sign up have twice as many problems and twice as many meds, twice as many meds. So what we've captured is the folks who need it the most, and that's the good news part of the story. The other part of the story, just while I'm sort of on that, is we are seeing an older population, because that's another question you would ask. So we have 37% of our folks who are in their 60s are online, 25% of folks in their 70s are online, and 10% of folks over 90 years old are online with us. So that age barrier is going down too. So, I mean, it's just a value proposition, field of dreams kind of thing. If you provide the service that they recognize as being good for them, they'll come. We also have a proxy service where either an adult can take care of their kids, but also an adult can take care of their older parents. And that's been very rewarding. I mean, they're almost tearjerker, the comments we get back saying, you've not only given, you've given back, part of my mother's life, because they now can be involved and they're equipped to help care for their mom. I think that's enough, talk about untapped resources. As we get old, and as you know, there just isn't the infrastructure to support that. But there's this untapped infrastructure in addition to us as patients. We call them informal caregivers. So your family members that are taking care of you are not only unpaid, but they're untrained. Imagine a world where we could actually give them knowledge about what to recognize in you. And again, now we can. We couldn't on paper, but now, let's say with a simple proxy, all of a sudden they can be in touch with what is going on with my mom or my dad and what is the doctor suggesting. That's an untapped resource. So in terms of the ways to deal with the healthcare costs, et cetera, these are IT-enabled ways to deal with it. But it won't happen if we don't have the HCI that can relate to an older person, for example. Did I address?
Not really. I wanted to know if the transformative effect could come
Oh, yeah.
short of
That's
interacting with the doctor himself.
And I think you do get partial credit. In other words, so a lot of those folks, the lipid thing, that's all part of the free part that doesn't involve the communication with doctors. When you do subscribe for the messaging with the doctors, that becomes the number one function. So I think that it is additive, but clearly you can have some of this transformation, the change in your behavior without it. Please.
Yeah, just a comment about the Mayo Clinic and Spark.
Yeah.
You know about Spark,
Yeah.
and Spark has what you were talking about in terms of the patient-doctor relationship, where they're sitting down with the patient and saying, well, what do you think will happen if you don't take whatever it is they need to take? And then that seems to have a profound effect on whether or not they're compliant or not. But my question is so some of the people, or a lot of the people, were happy with the system and using it and getting feedback, but some of the people weren't. So that includes the doctors and the patients.
No.
What were some of those things, and are you continuing to do the ethnographic research to say go to the next step? What's the next step, and what were some of the things that they weren't happy about?
A lot of people just want more. Couldn't it do this? Couldn't I upload, somebody mentioned, upload my data, my pictures and stuff like that. And some of the things we do not have the capability to do now, let's say upload pictures. The other thing we do not currently have, and part of it's a technical thing, the software doesn't allow us to, let's say, push out your X-ray result, your images. And the other consideration, of course, is bandwidth. So all of a sudden we'd be an immense burden on our infrastructure. But so those are pieces of it. People who have not subscribed, would rather it be free. But a lot of it has to do with couldn't we have even more of this stuff? And also,
Were there things that you're thinking of that are really important?
Well, on the top of our list, and this thing that we're going to do a clinical trial on, is disease management. So almost all of us, once we get past a certain age, let's say 60, are going to have chronic diseases, and probably more than one. And those will eventually impact not necessarily a lifespan. I mean, that's not the more important part, is our quality of life. And people are now wanting to do more and more about it. And so we want to give them the tools to do that. So chronic disease management, that's sort of the term of art, is what we're picking on. And diabetes is our first disease, because it has such big cost on the individual in terms of the quality of life. Heart failure is another, asthma, high blood pressure. In the end, basically, the high cholesterol and high blood pressure increase all of our risks of having a heart attack, et cetera. So we're just going out. And another part of my dream is obesity, and especially childhood obesity, because that is the next tsunami in terms of the incredible health burden. And what I'd love to do, and one of the things we're working on, is this phone thing, because every teenager sleeps with their phone. So that's just an attachment. And if there can be a way to make health a fun, maintaining health, improving health, beating health, if there's a way to do that with teenagers, that would be a big health intervention. Because as you know, most of our kids, or a big chunk, like a third of our kids, are overweight. And that's the gotcha that's coming downstream. So I mean, it's really chronic health maintenance or management. That's our biggest thing. And to take it outside of the environments of the four walls.
And are you doing the ethnography to go with that?
As a matter of fact, we are. Talking about diabetes, well, I'll go ahead. So I'll cite some results from, well, actually, no, too long a story. But yes, we're doing ethnography in the home, et cetera. Please.
Along some of the same lines that you were just saying, are you looking at other sensors? Specifically, have you thought about working with, say, the Wii Fit? I mean, it sounds a little silly, but that would be a high gain sensor to get a lot of that type of data. Have you looked at that? That would have most of the stuff you need.
I think what we want to do, so it's sort of like you want to go for the low-hanging fruit, but also you want to have a high yield. Because it's one thing to sort of go for the next toy, it's another to try to pick off the low-hanging fruit. So it turns out, so glucose monitoring is the lowest hanging fruit, although it's still invasive, because you have to still stick yourself. Coming, yes. In heart failure, it's your weight. We can do a lot just by knowing your weight. So before we get the whole body outfit and monitor everything, just simple things like weight and 5 questions will help us keep you out of trouble. So no problem with, I think we basically have to do remote monitoring or basically instrument activities of daily living is another way to look at it. So we can figure out together, with the computation, et cetera, to maintain and maximize and optimize your health. But right now there's so many low-hanging fruit, so much low-hanging fruit that we're going after those first.
What I more meant was what other sensors are you thinking of besides just the glucose monitoring?
Glucose, weight, blood pressure. For asthma, it's peak flow, for example. I would love to instrument your diet. If nothing else, to give you feedback, because I think that would be. I just heard an interesting thing from the Safeway, and they only have this in in certain markets now, but they're going to distribute it. Is how you have your Safeway card, right? You do this because you want the savings, but interestingly, they know what you're buying. So one of the things I always want to do is to have one of these UPCs on every food product, and then you just do one of this, right? And then it instantly tell you what the nutritional value is. And I think that would be nice. But the thing that's already there is the buying. So at least for a family, you know exactly what the family's consuming, and you even have some sort of time domain. So you could actually sort of plot, you could do an analysis of the purchased food, which I thought was very intriguing. Now, if we could get it down to the individual level, then I think we have it better. But that was actually an amazing revelation. So they're doing this in a test market, and they'll distribute it. But I think that could be really neat. Another example is the YMCA uses something called FitLinks. So you're lifting weights, and that's all going to the YMCA. You can see a computer of where how many Volkswagen you've lifted today. So I called the CEO up and said, "Oh, yeah, it'd be great if this stuff was available, in your health record." Well, it turns out it is on the internet. They just didn't advertise it at the YMCA. So you can imagine it, including that, and just basically having your stuff about your health there as feedback. And that's how you can see now it can be a game for teenagers. You basically, outlift other, whatever it is. But if we can create the incentive and the feedback for people just maintaining their health, I think that's all about the transformation. It still goes back to the information transparency. Please.
It seems to me like some of the users that derive the most benefit from this system might be the same users that would need special accommodations to use some of the the web interfaces and things like that. So can you speak a little bit to the accessibility of these systems?
I can't speak a lot about it because we don't know. All we know right now is the inferences we're making. By one, the people who are using this system are actually sicker by twice as much than our general population. So that's an indication that we're at least reaching a goodly portion of them. And the second piece is this whole age dynamic where more and more folks either have direct access or have access to their proxy, their kids who are helping them. So whereas I can't say what I'm doing for the entire population, we have hints that we are definitely reaching a segment that is sicker, could be helped more by this system. It's not a complete answer to your question, I know, but it's what I have right now. Please.
Where do you stand with portability? I'm being seen here at PAMP, and yet I go to Washington, D.C., I'm sick there, I'm maybe a diabetic. How do I bring my record if they don't have internet access in the emergency room? How does that work?
Okay, good. So you asked me a simple question first, which is how do you get access somewhere else? Well, almost every emergency room now has, somewhere in the hospital has an internet access. And this system, of course, you can access from anywhere, including foreign travel, of course. The other thing is, so far what we've done is if you leave us, we still are letting you access your information. So far our policy is that you'll have it for forever until we figure out what to do about it.
But it doesn't, by your own admission, it won't integrate necessarily.
It won't integrate. That was the harder question. It won't integrate, and we'll be, first in line. In fact, I spend a lot of my time on public policy trying to make that world happen. So we'll be among the first to step up when that happens. So somebody else mentioned Kaiser. Kaiser, turns out, so we were the first in the Bay Area to put in, I guess, an electronic record system and also Epic. It turns out Kaiser and Stanford are now going to be Epic, use the same product. So even that doesn't guarantee the exchange that you asked for. So but we are deliberately working together to make that happen. And those mean, these are these sort of one-on-one kind of negotiation to try to make data flow in an understandable format. Please.
Getting back to sort of the efficient medical care in the U.S. has been sort of concentrating on the dyadic relationship, patient, doctor, and also with a heavy reliance on communication. Collaboration is best supported by document communication about the documents. Right. So going back to examining, sort of teasing apart the dyadic relationship, have you looked at particularly in depth in terms of the kinds of in-office interaction in pediatric care, and then the kind of carryover where I guess, sort of backing out of it, most parents think of themselves as parents, not proxies. But that might be an avenue to really addressing in a tight situation the notion of what a medical health and longevity caregiver can contribute. Whereas at the other end, the older end of the spectrum, it's a lot looser. There's medical specialties aren't as focused as, say, pediatrics is.
So you have to get to the heart of your question. Yeah. What's the question? That's the background for the question.
The question is do you notice different value, different patterns of view, or in your pediatrics for this system when a parent is the primary point of communication?
A lot of our, okay, so here we go with public policy again. We have not had as in-depth experience with pediatrics for a couple reasons. One is getting the proxy system in place so a parent can be the proxy for their child. Now, the biggest problem we have is called adolescence, the gap. And they, ironically, have one of the biggest needs for this information. The problem arises because there are state laws, this is done at the state level, that govern what you can and can't do with a teenager, or more importantly, what a teenager can or can't do without your consent. It all has to do, pregnancies, sexual habits. There's a class of about 12 conditions that a teenager is allowed to get care without the consent or knowledge of their adult. Therefore, they have the ability to sequester that information from their parents. Computer can't figure this out. Then there's such, emancipated minor. There's all kinds of legal ways that teenagers have the right to confidential information. Since the computer can't figure that out, right now we have not been able to release information and make the service available to teenagers. It's because the computer can't do the right thing. And so rather than compromise their legal all right, but also their rights to this kind of care and information, we unfortunately have had to orphan it out of the computer sharing part, the PHR side. So we aren't as able to richly go into that community, unfortunately. Please.
Is the implication then that the caregiver gets set basically total access to that health record? Everything that's there, or I can't set just certain pieces that I want you to view as my caregiver?
Okay, so So this model is that you are sharing access to our record about you, okay? And you're viewing our record. There is another piece of it where you can write notes on your own, and that is private to you. We don't actually physically can't get at it.
Rules specifically?
Oh, yes, the proxy is the same thing. So that's why we stepped into it very gingerly, because we wanted to create, one, your knowledge. Let's say you're doing it for your parent. Your parent has to understand that you are now having access to his or her record, and you are acting on behalf of them. And we really wanted to make sure they understood that. But when you understand that and you accept that, it's really, really valuable to both parties. Same thing happens. It's less of a, for your under 12-year-old child, you do have those rights. I mean, because you are the parent and you have those legal rights. Then we have the problem of the in-between. Please.
So you mentioned this interesting system where complex technical terms in the document would automatically be hyperlinked and so on. So does that technology really work? What's the sort of false positive, false negative rate?
Well, it's because there's a lot of manual work. So basically, we took our high frequency, we have the whole corpus of text in our records. So we just look for high frequency terms and phrases, and then decide these are things that a layperson would probably have difficulty understanding, yet it's important. So we just sort of in rank order go figure those things out. Then the system simply looks for that phrase or word in anything going out to the patient, and then hyperlinks it. And then it has a database of what to link it to.
But other cases where there's a misspelling, so it's not recognized,
Correct.
or it's
Those are not
incorrectly
handled.
recognized and so on.
Yeah, those are not handled by this particular technology.
But do you see it happen in practice?
Happen that those errors, those missed opportunities that happen?
Yeah.
Sure. Yeah.
Great. Thanks very much, Paul.
Okay, thank you.
For information on other online Stanford seminars and courses, please visit study.stanford.edu.
The preceding program is copyrighted by Stanford University. Please visit us at stanford.edu.